community medicine. And before I start talking about all my hopes and dreams for Family Medicine VMR, I just want to remind everybody that we have a case presenter today, but we still need two discussants to discuss with Ramla and I. So please volunteer in the chat so we don't have to wait around awkwardly. I will say, so my brief spiel about Family Medicine VMR and what I'm hoping it might be is that CP Solvers has been just such an amazing space for me to hone my clinical reasoning over this last year and a half, 2 years. And I've loved the community, love everything I've learned from it. And I feel like my clinical practice in family medicine is so much more than adult internal medicine and adult internal medicine in the hospital. And so I'm really excited to have a space and to share a space with you all where we can work on honing our clinical reasoning skills about sort of folks through the lifespan and all the kind of people that we take care of in family medicine. And I'm excited to just have a space to build my clinical reasoning skills about kids and pregnant people and in geriatrics and in clinics. So I'm really excited that you're all here, and I will pass it to Ramla.
Hello, good morning, good afternoon, good evening, wherever you may be around the world. So I'm Ramla Kasozi, and I've been a longtime fan of CPS. I'm now an attending, which is interesting because it feels so surreal because when I first started with CPS, I was like a resident, like PGY2. And I've stuck with it just because, this is a great platform, which is very safe to learn your clinical reasoning skills. And I do want to tell you that it doesn't stop after residency. It continues even now as an attending, working with residents, because now I'm in another sort of position. It's quite interesting to sort of interact and also learn from them as well. So I love this environment because I also learn a lot from you all. So I'm excited to be here. Do we have any discussants? Please come out. We don't bite. This is so fun. Family medicine is just like the coolest discipline, I feel. We do all around. We discuss very freely. So please jump up. Maybe as we wait, a bit more about myself. So I am an IMG. I just recently graduated from the University of Minnesota at the St. John's campus Family Medicine Residency Program. So I always tell people it is possible for IMGs to go to university-based programs. I know a lot of people get worried and threatened by it. And if you ever have questions, feel free to, I think the best way to reach me is that Twitter handle, and you can DM me and we can talk about that. So I'm originally from Uganda, East Africa, but I also grew up in Canada. Went to medical school in Uganda, kind of been around the world before I settled here to do residency. But I was fortunate enough to do also my master's in public health at Emory University. So I worked a lot with CDC. My passion is refugee health, minority health. I'm very interested in race-based medicine, especially interrogating clinical algorithms that incorporate race, so like EGFR. I've done a lot of research in that area. I was involved with various task forces as a resident to remove race out of the EGFR. Currently, I'm working on the ASCVD risk calculator. I think most of you may know about it. It's a tool that's used to decide whether or not when to initiate statins. I personally don't like that tool because it has race. It increases the rate at which we prescribe statins. Hopefully one day we'll have a case to discuss that. So those are sort of my research interests, including hospital medicine. So that's the great thing about family medicine is that I could be in clinic, you can deliver a baby, but then you could be in the hospital and then you manage acute situations like heart failure. So yeah, that's a bit about me. I don't know if Simone, you want to talk about your interests in family medicine?
I will talk about myself extraordinarily briefly. I will then pass it to Cindy to introduce herself. She'll be presenting our case, and then we'll just get started. It looks like we have two co-discussants. We've got Hans and Gabriel. So my interests in family medicine are mostly inpatient adult medicine and taking care of pregnant people with substance use disorders and their babies. I would love to talk about those two topics with anybody all the time, but I'm going to pass it to Cindy.
Hi, everybody. Thanks so much for having me on. I'm Cindy. I'm a second-year resident at UCSF Family Medicine with Simone. Just briefly, my interests are also adult inpatient medicine. I'm also interested, like you mentioned, Ramla, in immigrant and refugee health, and hope to do more of that in my grown-up job. I guess I can kick us off. And do we have our discussions?
Yeah, we need to team up. So, Ramla, do you want to go first or second?
Either or, I'm cool.
You don't
I
care. How
yeah.
about you'll go first with Hans and I'll go second with Gabriel?
Sounds good. Ready, Hans? Yay, I'm excited.
Okay.
All right, Cindy. Yeah.
All right, I'm going to kick us off. So we have a 12-year-old boy who presents with 3 days of sore throat, cough, and severe knee pain, as well as polydipsia, urinary frequency, and urgency. On further history, the parents say that he's had 1 day of fever and vomiting. He denies any injury or trauma to his knee or leg. The knee pain started suddenly. It's an 8 out of 10 severity, comes and goes. It goes from the mid-thigh to mid-calf, but it's worse over the thigh and knee area. And he's been limping for 3 days because of the pain and finds it difficult to straighten his leg. On review of systems, he denies any headache, rhinorrhea, diarrhea, dysuria, foul-smelling urine, blood in his stool or urine, and denies any back pain, and he's not sexually active. I'll pause there.
Ooh, all right, Hans, you want to go? You share your thoughts.
And the
What are you
patient is
thinking?
12 years old.
12, okay. All right, so Hans, you want to go take a stab at it?
I was thinking about a
Hans, you're
boy.
muted.
Am I still muted?
Oh, no, I can hear you now.
Okay. No, I was thinking about a boy who might have caused some kind of a viral infection, sore throat, or even a bacterial infection that might then cause his sore knee. There could either be a post-streptococcal complication, but I was more thinking about a post-viral inflammatory reaction that causes knee pain. Now, he also noticed polydipsia and polyuria. So that rose the idea that probably he has 2 conditions. Maybe he's already predisposed to developing diabetes, which could explain nausea, vomiting, polydipsia, and polyuria in conjunction with his sore throat and knee pain. That was the first thought that came to my mind. So I have to be maybe a little bit broader with everything. I pass the mic on.
Okay, well, yeah, excellent. That's a great start. Especially with pediatric cases, what I find very interesting most of the time, especially is with my interaction with pediatricians and other doctors, children are, like to present in syndromes most of the time. And so that's sort of my approach. Whenever I see multiple symptoms, I'm thinking, okay, what is the most likely syndrome that could be happening? We're seeing here, first of all, it's a 12-year-old boy. Okay, so that tells me almost like, preteen child, because certain conditions happen in different age groups, right? The fact that it's a 3-day illness, we already know is an acute onset. But I think I would like to know more information as to, has this ever happened before? Has the child been around sick contacts? Has there been recent travels? So definitely we need more background information about sort of how was his health prior to that? And if there are underlying medical conditions, which I'm sure we're going to get information about. So he has sore throat, cough, severe knee pain, and polydipsia. So when I see this, definitely I'm leaning towards more of a viral. Could this be, yes, a viral infection? But the fact that there's polydipsia now tells me, okay, there's a renal component. So could this be some sort of like a post-infection sequelae of sorts? And now this particular organism is affecting the kidneys, causing the polydipsia. Now, he did have a fever and vomiting. And also, I think somewhere they mentioned, was there a limp? Was he limping? Also, yeah. And so I also get concerned about that, because then that tells me some sort of joint inflammatory process. So could this be some sort of like, yes, a viral infection? Could it be a bacterial? I think right now the differential is so broad at this moment. I definitely want to get more history before I still do labs, just to see what their medical history is like, what their meds, their recent travels, if they've had this before. So that's the infectious sort of bracket. Now, the other thing you could consider, yes, what if these are 2 different things happening, like Hans said? Is there an endocrinopathy happening because of polydipsia? possible as well. What if this is a type 1 kind of, presentation of DM? But usually with endocrinopathies, I mean, the whole sore throat cough kind of throws me off, not really in that endocrinopathy kind of picture. But who knows? This could be either two things happening at once or just one thing that just has this particular syndrome. So that's sort of where my thoughts are for now.
Sounds good. I'll give you a little bit more of a history. So in terms of the polyuria polydipsia, he reports that he's been drinking about 6 to 7 8-ounce water bottles per day, and he's been urinating about 4 times a day. No recent illnesses before this, no sick contacts, and no recent travel. In terms of his past medical history, he has a history of hypothyroidism and asthma, no prior surgeries, medications. I actually have no medications, but I'm guessing he's on levothyroxine. No allergies. Family history is non-contributory. And social history-wise, he's housed and lives with his parents. And on his vitals, we have a heart rate of 145, temperature of 38.5. His respiratory rate is 22, and blood pressure is 113/56. And he's sitting at 96% on room air.
Okay, Gabriel, take us away.
Yeah, sure. So when I see this knee swelling, I will try to differentiate if this is true arthritis, and I totally agree with Ramla and Hans. We have to ask also for the immunization status, because this kind of arthritis followed by an upper respiratory infection made me think, for example, in influenza type B, but that will be rare if this patient has previously immunized. But yeah, I will look at what's happening to the knee, because it carries so much morbidity if left untreated. Can also lead to osteomyelitis. Yeah, I will, and also for the acute presentation, I agree these infectious diseases are highly on my differential, but also I'm kind of thinking if this could be lupus presenting as arthritis, and also maybe with renal manifestations. Sometimes lupus can present as fever, is very sneaky. Also, although being more commonly presenting in females. Another thing that I'm thinking about if this could be two diseases starting together. For example, has mentioned diabetes, especially diabetes type 1 kind of fits in younger patients. And also sometimes when the patients with diabetes present with a concomitant infection, the clinical manifestation of the diabetes arise. So I will keep that also in my differential. And in the physical exam, we are seeing that the patient has signs of inflammation, such as the fever. So make us think also infections in our top of my differential.
Amazing, Gabriel. So one second, there's an echo in the room. Okay, so I totally agree with everything you said, and I'm not really going to say anything new, but I'm just going to maybe structure it a little bit differently to go along with the way I like to think about things. Right now, I feel like I have two overlapping schema in my head that I am trying to sort of put together. The first is just like an anatomical schema. I don't really know where this pain is coming from. You know, when we first saw the case, he had so many symptoms, and I was like, which is signal, which is noise, what is like our real, which symptom, if I follow it, will help me make the most progress. But then when I saw the limp, like Ramla said, like that makes me worried, and that makes me hone in on, okay, whatever's happening in the extremity, that is signal. So let me follow it. But we mentioned knee pain, but I don't know that this problem is in the knee. You know, whenever we're having a joint issue, an issue in extremity, we try to think about like the joint above and below it as well. And so right now, all I know is that he has, I don't know which side it's on, but unilateral lower extremity, a syndrome in a unilateral lower extremity. And anatomically, I'm like hip, knee, or ankle? Is it the joint? Is it the joint space? Is it the bones? Is it the muscles? Is it the tendons? Like what exactly are we talking about as our focus of the problem? So that's one. And to say, like, in most kids, most lower extremity problems are from trauma, but here we have no trauma and we have a signal towards inflammation. And so in addition to my anatomical approach, the second approach I'm thinking about is sort of the I-made mnemonic. I find that I still like am largely rooted in our adult schema and just sort of think about how to alter them for kids rather than having brand new schema. But I'm definitely thinking this is an acute inflammatory condition. And so going down the I-made mnemonic, infection is like number one. And I heard people mention, like, is this a bacterial infection? Is it a viral infection? Is this a post-infectious process? And the rest of the I-made mnemonic, like malignancy, I think I would think about this earlier in kids than in adults, because kids can have both like benign and malignant neoplasms kind of more easily than adults can, but I wouldn't think of 3 days of an inflammatory process as really pointing me in that way. Autoimmune, certainly folks in the chat have mentioned this person has one autoimmune condition, is predisposed to other autoimmune conditions. So it's certainly possible, but we're kind of early in it's a very short time duration. And then drugs and endocrine, I'm not so much thinking about right now. So yeah, I'm trying to figure out where anatomically are we, and most likely we're talking about an infection in whatever anatomical that space that is. But I think the exam will help us hone in on exactly where those two things overlap. Okay, Cindy, kick us away.
Great thinking, you guys. This is a really tough case, and I love all of the broad differentials for this. And I love that it's like a twist because it's a PD case, and so some of the things that we don't normally think about are a little bit higher on our differential. So let's move on to this patient's exam. So general, he's alert, active, well appearing. On his cardiac exam, he's tachycardic but regular rhythm. His lungs are clear to auscultation. His abdominal exam is pretty unremarkable. Skin exam, no rashes found. In terms of his extremity exam, his cap refill is less than 2 seconds. His left knee is slightly swollen, but there's no erythema, no lesions except for scattered small bug bites on both legs without any evidence of surrounding infection. He has left knee pain to palpation, but he's kind of distractible during the joint exam. And he does have some pain just superior to the knee, kind of in his lower thigh area, that does persist despite attempts at distraction. He has pain with trying to extend his leg, and it's hard for him to bear weight, but there's no joint effusion. You also obtained multiple labs, but being that this is urgent care, none of them will have resulted before you send this patient home.
All right, Hans, you want to take it away? Oh, you're muted.
Yeah, I'm muted, but now I'm back. The bug bites are kind of striking me as well. Now, I don't know how they fit in with his sore throat. And of course, the question that we asked in the chat was, where does he live? So we might get an idea of what kind of an infection he might have caught from the bug bite. His physical exam appears to be, except for the musculoskeletal and the knee exam, within normal range. Tachycardic, probably because of his fever, the pain, and his infection, but otherwise it looks okay, except for the extremities. He certainly has some problem there, and I can't figure out what it is, except maybe transient synovitis, which was mentioned, which is a sequelae of a viral infection, but it could be more. Maybe the bug bites is just kind of a distractor that we can ignore, but at that point I'm inclined not to. But he has no rashes.
Mm-hmm.
So I have no further ideas. I would rather look for the labs now. They seem to be more interesting.
Yeah, I mean, good thoughts. I like that, Hans. Great job. Definitely, yes. Like Simone said, you can use like really the IMAID. I also kind of had that in my head to kind of decipher where we're at. And what I found interesting is, yes, that knee pain that is sort of with the swelling is slightly or swollen. There's no erythema and there's no rashes, which is reassuring. And like you, Hans, I'm thinking, do I need to care about these bug bites or can I ignore them for now? My concern is whenever I approach a case, also another sort of what goes in my head is, what is going to sort of kill this person first if I don't find out what it is? Is this person stable, not stable? What I need to do to save their life. What I'm afraid of right now is some sort of septic arthritis in this child. Whenever joints are involved, we know he had a fever, it's now swollen. This is a person where I'm worried about some sort of bacterial infection in the joints. And that's sort of my go-to. And sometimes, like I know with the IMAID, it says malignancy. And yes, some of his symptoms are acute, but once again, we could assume that it just happened now, but for some children, you don't want to ignore this knee pain. That I would definitely be interested if the child can tolerate imaging of that knee, specifically like an MRI. Whether or not it needs to be tapped, that's also another question, just because we need to figure out, is there something there? But labs will give us more information. But with this presence of a knee pain, I'm kind of leaning towards some sort of like an infection that's just now become giving these other symptoms, which are more of like a post-infectious kind of picture. Most common infection kids get, of course, are like streptococcal. This could be a streptococcal sort of sequelae of sorts. Could this be viral? It is possible. I mean, the fact that there's no rashes, that's reassuring, because there was a part of me that was thinking, could this be Kawasaki's, but he's too old. We don't see any like history about his lips, any cracked lips or any buccal lesions or anything like that. But that's kind of also on the differential, because that's what sort of gives that constellation. But what's against it, he's a little older and there's no rashes. So right now, I'm really concerned about the joint, because I don't want to lose the joint. And I feel like I need more information about that. And it will kind of let me know if it's the cause of his sore throat, cough. But I wonder, Cindy, do you know which symptoms started first? Was it the sore throat, the cough, the knee pain? Like, that's another history that I would need, is like the chronology. I don't know if I missed it, of symptom onset. Do you have any information on that?
I actually don't. I don't know. This is our co-resident who saw this patient. My hunch is I think the sore throat, then the knee pain.
Okay.
But I will try to find out.
Okay, that's okay. Because then that also tells me, like, I would like to assume too, let's assume he had the sore throat, the cough. He was probably kind of still going to school. And then I think what tipped him over was the whole knee pain and then the polygypsia. And so that further reinforces sort of my idea that I'm now sort of in the infectious sort of bucket. But it's possible, because of this infectious process, we're now entering an endocrine sort of area. But my worry right now is his joint, to make sure we're not dealing with some sort of septic arthritis. Yeah. Thank you. Maybe you give us more info on the labs.
Yes, the labs are important. So next you have a telephone encounter with the patient to follow up the labs and check in on his symptoms. So he was discharged home from urgent care. The provider calls the family a week later and the kid is doing okay. He's sometimes going to school, but is having high fevers and vomiting, and his knee pain is getting worse. And his labs are finally back, so we can review them. On his CBC, he has a white count of 11.9 and a hemoglobin of 12.2. Platelets are 344. On his BMP, he has a sodium of 134, potassium of 3.7, chloride of 101, bicarb of 25, a BUN of 11, a creatinine of 0.68, and a glucose of 95. His LFTs are within normal limits. On his UA, he has no glucose, trace ketones, no leuks or nitrites. He has 6 to 10 RBCs, 2 to 5 white blood cells, and moderate hyaline casts. We also got some other labs. He has a TSH of 9.7, which is elevated, but his T4 is normal. His CK is also normal. ESR is 65. CRP is 148. His ANA is negative. C3 and C4 are normal. We also got a strep antigen that was negative, and his anti-streptolysin O is normal, and his gonorrhea and chlamydia test is also negative. The provider asked the family to present for reevaluation. On exam that day, his heart rate is down to 102, he's afebrile, and his vitals otherwise are normal. His left knee and thigh are still slightly swollen with some faint erythema on the thigh, but not on the knee itself. And he still has pain with leg extension. It's difficult for him to bear weight on the affected leg, but he can walk a few steps with a limp. And his tenderness to palpation is worse actually at the back of the knee and in the thigh muscle superior to the knee. So he's sent to the ED for further eval. He has an X-ray of his knee and his femur, which are unremarkable, and he has an ultrasound of his lower extremities, which showed no DVT. And the patient is admitted. The next aliquot will reveal the diagnosis. I also saw a question about the calcium level. I don't have it written down, but it was normal.
Sorry, can you repeat the findings in the ultrasound, please?
Yeah, the ultrasound showed no lower extremity DVT.
Oh, thank you. Did you have any urine osmolarity?
I don't have it written down, but it was normal.
Okay. Yeah. So I was pretty shocked by the findings by the labs and imaging, because in the ultrasound I was expecting more signs suggestive for septic arthritis, but I know that can sometimes can be missed. It not always is this kind of accumulation of fluid around the knee, but there are also in the lab some markers of inflammation. For example, the erythrocyte sedimentation rate and the C-reactive protein are high. So kind of put also in my infectious category high. Still, I'm thinking about infections. But for the kind of polyuria, polygypsia, I cannot explain it too well, maybe because of the fever. The patient was losing water and he felt really thirsty, and he started feeling that sensation of drinking more water. But because I was thinking maybe about maybe some insipidus diabetes, but the urine osmolarity was normal. Sometimes if this is too low, it can help us to prioritize this type of diagnosis. And with also the past medical history of hypopituitarism, I was thinking maybe this patient can have in the past medical history of hypothyroidism, I was thinking maybe this patient has a diagnosis of hypopituitarism, but the TSH is not low that I could expect in this condition. But yeah, this seems like a disorder of the thyroid gland, not a central hypothyroidism. So yeah, still I considering evaluating the fluid of the knee. Maybe that can help us clarifying what we are thinking and start some treatments, because as Ramla said, septic arthritis carries much morbidity.
Amazing. Okay. I totally agree with you that I don't feel super satisfied that we have a explanation for the polyuria or polygypsia right now. So I'm actually just going to put that aside for a second because I want to kind of like Ramla said, focus on the things that I know are there and that I know are dangerous. And, you know, I left off the last time I discussed saying that I was feeling like I was trying to overlap these schemas of anatomy and infection and IMAID. And I think, you know, thinking about IMAID, I feel pretty good about saying we need to think about infection first, but anatomically, we've lost the whiteboard, huh? Well, okay. While we try to get that
I went away for a second.
Anatomically, I feel like thinking about this exam, I don't feel convinced that I know that the problem is in the knee joint. I agree that a septic arthritis would be very scary, but oh good, it's back because I wanted to talk about it. So let's see, the left knee is swollen, slightly swollen, and has pain to palpation, but is distractible during a joint exam. And I feel like what I've learned, at least in adult medicine, is like, if I think that the problem is within the joint, then the pain is really when you do the joint loading. And if you don't have pain with joint loading, then you need to think outside of the joint space. And so, not to say that I'm taking it off my differential, certainly I'm worried about it, but I think it's interesting that the pain is really in the back of the knee and then superior to the knee in the lower thigh. And that makes me like, okay, if I think about my anatomy and what's there, we have sort of the femur and the muscles surrounding it. Okay, and then looking at our CK is normal, which kind of makes me think it's not the muscles surrounding it. And so now I'm thinking, you know, behind the knee, what might be behind the knee? Is there some sort of abscess behind the knee? Because that's where there's a lot of palpation. Or is there an infection of the bone? And then I remember that I last year when I was on peds saw a kid who had like osteomyelitis that was hematogenously spread. And I learned that the way I need to think about osteomyelitis in kids is really different than adults. So like when I see osteo in adults, it's almost always, well, it's like two cases. One is somebody with a diabetic foot ulcer there's just local extension of the infection into the bone, or it's like somebody with IV drug use who has an infection of the bloodstream and then that seeds somewhere in the body. But what I learned was that in kids, you can just have like these transient random bacteremias for not any great reason. And then you can get osteomyelitis. All of that is to say, I am wondering, are we outside of the joint and are we in the knee and are we in the muscles? Are we in the thigh and are we in the muscles around the knee? I'm sorry, around the thigh? Are we in the bones of the thigh? Are we in a space behind the knee that I don't have like a great sense of? I don't know what to make of the red blood cells in the urine. Somebody mentioned post-strep glomerulonephritis here. The strep was negative. And I think what's making this hard for me to think about is like, you know, in kids, when I see I think about infectious processes and then post-infectious processes, but this kid actually still has some sort of infection going on, like with the cough and the sore throat. And so I think we're not really in the time frame of a post-infectious process from whatever's causing his cough and his throat. We're not in the post-infectious period of that. We're in the active infectious period. Not to say that there couldn't have already been an infection in the past, and that we're in the post-infectious phase of that past infection. And now we're presenting with a post-infectious process. So I think those things are a bit muddy for me, but overall, just to like bring myself back, I think we have a kid with a history of autoimmune disease presenting with a acute inflammatory process, with evidence of inflammation by his fever and his elevated ESR and CRP, presenting with pain in a left lower extremity, somewhere superior to the knee. And still, I haven't ruled out that it's actually not the joint above and below. And I just want to say that out loud, that we still need to be thinking about that. The x-ray of the knee and the femur is not super reassuring to me. That would really only help us with like a fracture. So it doesn't, and you know, it doesn't really help me with inflammatory processes. So the fact that it's unremarkable is not really reassuring. The DVT is interesting. I don't know that I would have immediately thought of a DVT, but that certainly can cause inflammation and in a localized extremity. So glad to hear that it was negative. those are my sort of scattered thoughts. Since the next aliquot will have the diagnosis, I'm wondering if anybody has other thoughts to add.
Yeah, those are great thoughts, Simone. I was also thinking about like, even though the imaging, the X-ray, oh, sorry, was that me? I have no one here. I don't know why there's an echo. But yeah, I was thinking like an MRI, I would want more imaging for, sorry, did the echo go away? Yeah, okay, great. So yeah, for me, even though the imaging the X-ray was normal, there's a part of me that still wants an MRI because he's still having issues. Like this is like an office visit, return visit, and then he had to go back to be admitted. So things are not looking good. So once again, I'm really concerned about that joint, especially if he's still limping. The other thing, at least the exam, you didn't mention any like abnormal bumps or lumps or anything, because another thing I forgot to mention, I would be concerned is like osteosarcoma of sorts. You know, that's another thing to make sure we're not dealing with. Those are very cryptic ones because they usually come in with an acute situation. You know, a kid could be playing soccer and then all of a sudden has leg pain, or they have fever and then they have leg pain, and they don't realize they've had it until they have that particular injury or situation. But it sounds like from the history, there was no swelling, no lump. So we're not worried about osteosarcoma. Right now, my top up there is definitely some sort of septic arthritis. I do want synovial fluid. I'm hoping the final aliquot reveals that, and hopefully you guys did an MRI, I hope, just to make sure there's we can ensure that the integrity of the joint is okay, just because an X-ray is not enough. So that's sort of where my thoughts are. But yeah, I totally agree with Simone that could this be an endocrinopathy happening at the same time? Could this be just a post-infectious sequelae that has caused this constellation of symptoms? But all in all, very interesting case. I'll be honest, I'm a little stumped. But this is family medicine, and that's why, you know, we have multiple visits to make sure we are seeing how you're doing. All right, go ahead, Cindy.
All right. Great discussion. This is definitely a tricky case, and I think sort of complicated because there's so many kind of interesting little things to kind of jump off of, and each one of them has their own very broad differential. But to bring it home, on hospital day 1, you get the following lab and imaging results back. His blood cultures, 2 out of 2 are growing MSSA. You get an MRI of his femur, which shows osteomyelitis of the left distal femoral metaphysis with adjacent subperiosteal abscesses and additional rim-enhancing abscesses in the surrounding musculature. He did not get his joint tapped, as far as I can tell. I believe ortho wanted the MRI first. So that is all the information I have.
I wonder if folks have any of the discussants have any reflections on the case or the resolution. I know I certainly did, but I'll let you guys discuss first, actually.
I see Kushal mentioned respect the staff as always. You want to talk? I like that. If you're able. No.
Yeah, I was wondering how did the staff get in there? Maybe from the bug bites, but yeah, staff is always mysterious and ends up sneaking in the diagnosis. And in retrospect, it would cause all of this, but we didn't think of that.
Yeah, Cindy, did you guys get any history about that? Because that's what I was kind of thinking originally. That's why I wanted to know. The one thing with peds, and pediatricians will tell you, is like, what is the chronology of these symptoms, you know, and what was the entry point? I mean, I suspect, yes, he could have had that throat infection, and this is like a post-streptococcal kind of like sequelae sort of situation. Do you have any more information on that, Cindy, or?
I believe that the sort of sore throat started before the knee pain. I don't know that we ever got like a very good sort of definitive answer on where the bacteremia came from, but like Simone alluded to earlier, this is one of the things that's really tricky about kids is like sometimes you can just have bacteremia without some of the typical risk factors that we think about in adults. And you'll kind of get this like very random phenomena of transient bacteremia, and it's enough to sometimes seed and cause osteomyelitis. So just a reminder to, like you guys have done, keep a broad differential and be thinking about all of the possible things that could cause it, because I certainly was not really suspecting it in this case.
Yeah, because it almost sounds like it's like he had a pharyngitis, like a, maybe I'm just jumping in, but like a beta hemolytic streptococcal pharyngitis, and it just, you know, gave him a sort of like this post-streptococcal glomerulonephritis. That's sort of where I'm at right now based on what you've told me. Sounds like at least his cardio exam was okay. So because the other concern we get, you know, worried about is rheumatic fever, right? And he didn't seem to have like any other issues, despite it was just more of the joint. So he had a suppurative like complication, and that's another thing you have to watch out for. There's a great article, I don't know if how to get everyone access to, but as family medicine physicians, you know, we like to use the AAFP, or the American Academy of Family Physicians, has really great article called The Management of like Group A Beta Hemolytic Streptococcal Pharyngitis. And so, you know, what you're afraid of most of the time is those suppurative like complications, like we saw in this child who had the osteomyelitis. Watch out for the endocarditis. Some people may get even a meningitis. Especially the fact that he was not improving. Always in my head, I'm like, what is the first thing that's going to, you know, cause more mortality, more morbidity? And I'm glad we kind of focused on the joint. But you're right. Remember earlier, I saw the bug bite. So I was like, should I ignore it? Should I leave it in? I mean, who knows? Could that have been the entry point? I don't know. I'm still more tempted to think that it was the sore throat and it just caused sort of like a complication and presented all these symptoms. Any last reflections from you, Simone, about this?
Yeah, I think my one reflection is that, you know, I think my big reflection on this case is what makes it so challenging is that there are still so many symptoms that we like can't fully explain. And I think that makes it hard. And you know, there is a sore throat and a cough, but all the strep testing was negative. And so I wonder if that is actually a red herring and this kid like had a viral syndrome in addition to having MSSA bacteremia. And that is what's making it hard for us to parse out. That's not to say, you know, I actually don't know the sensitivities and the specificities of strep testing. And so it's possible that they're a false negative, but when I think about post-strep glomerulonephritis, I think of it as 10 days after the infection. And so even if it was a false negative and this is indeed strep, I think we're not in the right time course. And so I do think it's a red herring. And I think, big picture, what this makes me reflect on is like both the beauty and pain sometimes of family medicine is like the uncertainty in which we need to live. And this case, while on one hand, like we have a diagnosis that definitely explains his most dangerous symptoms, we don't have like a clean gift wrap around this whole case, which makes it, you know, makes me keep wondering and keep learning, I suppose. I'll pass it to Rafa to do our teaching points.
So first, thank you, Cindy, for bringing the case. Very interesting one. And thank you, Simone, and thank you, Ramon, for facilitating the first ever Family Medicine VMR. And thank you also, Gabrielle and Hans, for discussing the case with us. So we had a 12-year-old boy with sore throat, cough, and severe knee pain. And first we thought about infections, especially viral, post-infectious causes, or maybe a bacterial. We thought about strep pyogenes. Always good to check the immunization status in kids to see if they're more prone to develop certain types of infections. And then we saw that this patient also had polygypsia on the background, and this is defined as severe thirstiness, and we could see that in type 1 diabetes mellitus that predisposed to infections, diabetes itself, but also post-infections complications. And then we saw that this patient had the polygypsia, and we can actually characterize that divided into two buckets, primary or secondary. Primary cause, it's also called psychogenic polygypsia, this is much more common in patients with psychiatric illness, like schizophrenia. A secondary cause, if you think about diabetes mellitus and insipidus, but also in cases of hypovolemia or increased osmolarity. And then we saw that this patient had knee pain, and we thought about trauma, but there was no trauma in the background. So we tried to combine the knee pain with the fever, and we thought about infections, malignancy, osteosarcoma in the case of a kid, for example, autoimmune, especially because this patient had hypothyroidism in the background. And we know that one autoimmune disease is exposed to others. And we also thought about drugs and endocrinopathy, less likely because there was no drugs on the background as well. And Ramon reminded us to think about the do not miss diagnosis in this case, especially septic arthritis, because this patient had difficulty to bear weight, elevated CRP, ESR, and also fever. And we have to remember that septic arthritis, the microorganism can enter the joint space by hematogenous spread, direct inoculation, or extension of a contiguous focus of infection, in this case, osteomyelitis. And osteomyelitis in kids, we have to remember that it's different from adults in a sense that acute osteomyelitis is primarily hematogenous in origin. In this case, we have to look for a source of the bacteremia, even though most of the cases are challenging to find. So thank you, everyone. I hope everyone have a good session. I hope to see everyone tomorrow.
One last thing I want to say, and before everybody goes, is this: we are really excited to create this space, and we also don't know what it will become and like what we hope for it to become. We hope for it to be a space where for us to discuss clinical reasoning of sort of all people across the lifespan, but we also are open to having it evolve with time and with the people that come. So we hope to see you at the next one. If you have a case that you see in the next couple of weeks that you want to bring, we'd be so excited for you to bring it or to come discuss with us. So yeah, thanks everybody for coming. Thanks Rafa for and Daniela for describing and doing the teaching points.